Good morning. I'm Dr. Dan Skeest, and it's my pleasure to introduce our speaker today. But before we get started, you'll be getting a survey from continuing education that we're going to send out just about grand rounds. Obviously, the format's been different this year. We learned that one thing we learned is that the remote or virtual presentations are actually work better in some ways, and the best thing is we get more people to attend. So that's great, and also they can watch the grand rounds later because it's videotaped uh, and on the hub as this one will be as well. So let's get started. So it's my pleasure to introduce our speaker, who's known to most of us, Dr. Harry Hoar, who did his residency in Med Peds at Baystate. Then he was chief resident in medicine, and now he's assistant professor of pediatrics, and he's a pediatric hospitalist. But he also sometimes can occasionally help out as a internal medicine hospitalist because he's trained in both. And he's really developed over several years now expertise in clinical decision making, diagnostic errors, and I've seen him give grand rounds a couple of years ago with Dr. Salvador. It was excellent, and he has numerous teaching awards. I can't count that high, so he's got so many teaching awards. So you're in for an excellent presentation today, and thanks for joining us, Harry.
Great. Thank you for having me, and I'll go ahead and get started. So today, the title of this talk is Obese, Black, Female, and Misdiagnosed. And we're going to talk about the role of implicit and structural bias in misdiagnosis. So I'm gonna jump right into it and tell you I have no disclosures other than the fact that I am not a Black female. I'll leave it up to you to decide whether I'm obese or not. But I'm going to put that out there up front. We're going to talk about that. Why is someone like me giving a talk like this? And we'll get to that pretty soon. Here's our CME code today. It's also in the chat. It's for those who aren't seeing what's on the screen right now. It's F as in Frank, O, P as in Peter, P as in Peter, E, V as in Victor. So my objectives today, I want us to be able to list the patient characteristics, so the features of patients, who they are, where they come from, all of that, that increase the likelihood of us committing diagnostic errors in their case, to discuss the role of implicit and to some extent structural bias in misdiagnosis, and of course to talk about methods to minimize the impact of implicit bias in clinical decision making. So we have indeed talked about diagnosis before and talked about bias in diagnosis before. So as a chief resident in 2008, I gave my first ever grand rounds on clinical reasoning, my first presentation on clinical reasoning, and we talked about a few different biases, including confirmation bias, which is one of the ones that's quite a strong tendency of the human brain. We will talk a little more about that later on. And then 3 years later, in 2011, I was able to come back and talk more about diagnostic reasoning. And I did at that time talk about many cognitive errors, including premature closure here. And I will point out, you see Dr. Armando Paez there. This was before he became sort of regionally famous COVID destroyer. He was a junior faculty at that time and was my example of someone who made a clinical diagnosis quite quickly and fairly easily in a case in which I personally had struggled for a while. So that's why he's up there, and he's remained one of our leaders here. 3 years after that, I was able to come back, and this time with Dr. Salvador, and talk about diagnostic errors again. And in that case, we talked about bias, and I mentioned that there are now over 100 biases that have been identified that are operational in some way in clinical decision-making. And then 3 years after that, I was back with Dr. Salvador, and we talked again about diagnostic error with an update, and I talked about the cognitive bias cascade, which you can see a slide here of some of the most common cognitive biases that do lead to premature closure and misdiagnosis. So we've covered this ground in the past, but we've never at all talked about something like this. And as I said, I am a white male, and so I think I want to give you a little bit of background of how is it that I am up here talking about this particular topic. And it certainly comes from a long-standing history of studying and knowing about cognitive bias, but I've never really delved into the area of implicit bias and racism and sexism and all the things we'll talk about today. So a little bit of background on how this talk came to be. Every year for our UMass Perch students, I give an introduction to the second year class prior to them starting their third year about pediatrics, just what to expect when they get into their pediatric clerkship. And I try to make it case-based, and I try to give them some pearls on the approach to pediatrics. And so I say things like, childhood is full of transitions. Lesson 2, you're treating the patient and the family, not just the patient. Lesson 3, you've all heard this, children are indeed not little adults. And then for lesson 4, I'm going to get into a little more of the detail. This comes from the presentation I gave the students back in late 2020. So the fourth case I talked about was a 20-year-old female with pneumonia who's a patient I took care of at Baystate in the Children's Hospital. So in sign out, I get this patient was admitted overnight by a night float resident. And then I come in the morning, and this is what they tell me about the patient. It's a 20-year-old college student, history of anxiety, who's on Valium, who was admitted with pneumonia. She's complaining of a lot of chest pain, but she's not on oxygen. She's just really highly anxious. So I look at her x-ray, and this is her x-ray, and she definitely has a left-sided infiltrate that's fairly significant. And as I'm going to the room, the nurse pauses me and says, "Hey, I just want you to know, she's really anxious. When she doesn't know that I can see her, she's fine. But when she sees me, she starts complaining about how bad she feels and her chest pain and all of that, just so you know." So I go in, and before I even introduce myself, this young lady says to me, I think I'm dying. Those are her first words. And I try to be reassuring. I say, "You're not dying. I've seen your chest x-ray. You have a pneumonia, which can certainly make you feel really sick. But this is something we can treat. And let me know if you need anything for your anxiety." So I'd like to think I didn't completely blow her off, but I also came in primed. This is an anxious young lady. And so I'm gonna, try to reassure her and not take her concern of "I think I'm dying" too seriously. A few hours later, she indeed got significantly worse. Rapid response was called. She was transferred to our pediatric ICU. Over the course of the next couple weeks, this is what her chest x-ray did. So you can see that it worsens, it becomes bilateral. Here's a CT scan that shows really bad stuff. And this is before any of us had ever heard of SARS-CoV-2, by the way. So she got sick enough that she was in the ICU and actually had been transferred to the medical ICU for a little bit of time as well. She didn't come back out to the floor for about 2 weeks. And in the meantime, she had a lung biopsy and a tentative diagnosis of some sort of interstitial pneumonitis type of process was made. So I come and talk to her and I say, I want to apologize to you. When I met you, I was under the impression that you were very anxious and that you just had pneumonia, and you told me, "I think I'm dying," and I didn't really think that was the case, but you came pretty close. You got really sick, and so I just want to apologize that I didn't take your concerns as seriously as I should have. And I said, I had heard that you have a history of anxiety and that you take Valium, so I think that sort of influenced my thought process." And she laughs and she's like, "Anxiety? Are you kidding me? Talk to my friends. I'm the most chill person you'll ever meet. I'm super chill. And Valium, I went to urgent care about 3 days before I came to the hospital, and they said to me, 'Oh, here's some Valium because you seem anxious.' I didn't even fill that prescription. I've never taken Valium in my life. In fact, the weekend before I got sick, my friends and I were in New York City. We were vaping some marijuana. We were having a good time. I'm totally chill." So it was shortly after, this is a little bit before we'd heard of vaping-associated lung injury as well, but we put the pieces together a bit later and were able to confirm she was indeed probably our first case of vaping-associated lung injury. So I told this story to the medical students, and then I said, here's the lesson from the pediatric standpoint. Lesson number 4 is the frontal lobe doesn't fully mature until age 25. And my goal here was to say adolescence is a time of risk-taking, and that's actually a normal, developmental, healthy thing that happens during adolescence. But you need to be on the lookout for it, and you need to make sure you're asking the sex, drugs, and rock and roll kinds of questions, because the risk-taking behavior of adolescents sometimes can impact their health. So that was my lesson. And the next day I got an email from one of the attendees who wrote, there's a lot of literature around women, particularly young women and women of color, being ignored or dismissed as emotional or anxious or attention seeking. This is an ingrained part of healthcare culture that has serious, sometimes deadly consequences. This literature also states that discussing this bias plainly is the best way to treat it. The emphasis there is mine, not the students. I was bothered today when we discussed this patient that was dismissed as an anxious young woman by the healthcare team, despite not having a history of anxiety, and that we attributed what happened in her case to an immature brain. So conversations ensued with this student, and I apologized for that and sort of was kind of, hand to the forehead moment of, duh, geez, what a bad example I set there, and how biased am I that I really didn't even think that this was something that I should be talking about. So we discussed how are we going to approach this, and what we decided was, I'm going to come back and give you guys a talk on and learn about and give you a talk on the role of implicit bias and disparities in diagnosis. So how does implicit bias really lead to poorer diagnostic performance? So I gave that talk. As you can see, this was February 18th of this year. And I revisited this case, and I said, I realize that I missed an educational opportunity here. So let's go ahead and let's talk about this. And I then delivered content that's similar in a lot of ways to what I'm going to be talking to you guys about today. And sure enough, I got another email from a different student. I unfortunately feel that your presentation missed the mark. You, as a white man, spoke about gender bias to a group of mostly female-identifying people. I don't need to be told that gender bias in medicine exists. I've experienced it. She goes on, I appreciate the self-awareness and that you realize that you yourself perpetuated some of these biases and then learned more about the issues and wanted to create change. However, I think that part of our commitment to incite change as people with a lot of privilege must be asking, am I the best person to give this talk? Is my voice the one that matters? So I'm not going to go into how what we've done since then in response to these concerns, and I am going to move forward. But I just want to point out that this is a topic where there's a lot of emotion, and I think that's well founded, and I think we need to do better for sure. So I actually was now a week after that first talk, and I got that email saying, a female identifying crowd doesn't need you to tell us that gender bias exists. And so here I am now preparing to give a similar talk to OBGYN. And I'm nervous about, oh man, they're going to think I don't belong up here. This white guy can't come to them and talk about gender bias and racism. And it was on this exact day, as I'm driving in to give the grand rounds in OB, you'll see February 25th here, that I listened to this podcast. This is from Clinical Problem Solvers, their Anti-Racism in Medicine series. And they were talking about this topic here. And one of the speakers, Giselle Corby-Smith, while I'm in my car about to give this talk, she, who is a professor of internal medicine, she's at North Carolina, she's the chair of social medicine and health equity research, she says in this podcast, It's completely irresponsible to think that we Black physicians are going to be the ones to fix this system by ourselves. White folks need to step up. They need to do the work to be able to understand, to be willing to be uncomfortable. How uncomfortable are people willing to be? So that fortunately inspired me to go on and give that talk, and to go on to give this talk as well. So I want to go ahead, and let's get uncomfortable. And again, my expertise is in clinical reasoning and cognitive bias. So I'm going to focus on this from a diagnosis and a diagnostic error perspective. There's many other things that we can talk about and have them been talked about in the internal medicine department already, and will continue to be talked about. I'm going to focus on diagnosis today. So here's the case that is the backdrop for the evidence and the data that we're going to go on to discuss. So let me give you a rundown of this case. So we have a 17-year-old female who presented to us in the Children's Hospital with respiratory symptoms. This picture is not the actual patient. This is a freely available image from the internet. So she had several months of dyspnea and cough before she was admitted. She'd had a chest x-ray previously that showed an infiltrate. She had been given antibiotics without improvement in her symptoms, and now she was presenting to us with worsening dyspnea and cough. She did not have a fever. She was not hypoxic on presentation. Her past medical history included asthma. She'd had multiple recent steroid courses, and she was morbidly obese with a BMI of 54. She had a CT angio on admission. There was no pulmonary embolism, but it showed worsening of the previously known left lower lobe infiltrate. So on hospital day one, we got pediatric infectious diseases involved, and they recommended we broaden our coverage to include atypical organisms, and also that we should consider non-infectious causes for this patient. On hospital day two, PDID is recommending bronchoscopy and a workup for autoimmune causes. Hospital day three, we note some eosinophilia that persisted throughout most of the rest of this hospitalization. And ID again is saying, we'd like a bronchoscopy and we'd like you to do an autoimmune workup. We're not sure that this is truly infectious. So in hospital day four, a high resolution chest CT is done, which shows badness, nodularity, severe consolidation with cystic change, necrosis, and other findings. And the radiologist in their report says, I recommend a bronchoscopy. So we get PD pulmonology involved, and they also agree, yeah, I think this is autoimmune. But I don't think bronchoscopy is going to help. I think you need a wedge biopsy. Rheumatology sees the patient at this time and agrees, yep, this is something autoimmune. We need a wedge biopsy. And they go on to say, bronch is not going to be sufficient. A tissue diagnosis will need to be made in order for us to determine the appropriate therapy for this patient. So pediatric surgery gets involved, and their impression is, yeah, actually, we do recommend a bronchoscopy, not a wedge biopsy. And ID and rheumatology clearly document and shared their disagreement with that. So in hospital day six, adult home is consulted, and they do agree to go ahead with a bronchoscopy the next day. But the next day, hospital day seven, the bronch can't be done because of some scheduling difficulties. Hospital day eight, bronchoscopy is performed. The transbronchial biopsy is attempted, but it is unable to be done for technical reasons. So on hospital day nine, she now has a new oxygen requirement, and we're just kind of hanging out, waiting for the results of these bronchial washings. Hospital day 10, adult pulmonary says, all right, we got the bronch results back. They're non-diagnostic. We agree with all the above. She needs a wedge biopsy at this point. PDSERG says, well, not all the tests are back yet, so we don't recommend a wedge biopsy. You could consider consulting adult thoracic, or you could think about a CT guided biopsy by an IR. So we speak to pathology, who says, no, we need a wedge biopsy. We need to see some blood vessels to make a diagnosis in this case. An IR needle biopsy is not going to work. The family at this point, this is not the first time, but the family is saying, can we be transferred somewhere where they're going to do something? We've done really nothing. We haven't been treating whatever is going on really at all. We had stopped the antibiotics several days prior, and they wanted to be transferred. That didn't happen. She stayed with us, And on hospital day 11, she seemed to be getting worse with increasing O2 requirements. So we do consult adult thoracic, and the resident documents no indication for surgical biopsy. And so I say, seriously? And we confirm with the pathologist, who's like, yes, I really do need tissue. So a conversation with the thoracic attending, who says, all right, we'll consider a biopsy, but let's get a repeat CT first so we can plan where we're gonna get the tissue from. So we do the repeat CT on hospital day 12. The radiologist says, yep, this looks worse. And thoracic surgery agrees to do the surgical biopsy in 3 days. Why 3 days? Because hospital day 12 happens to be a Friday, so we're going to plan to do this on a Monday. Hospital day 13, the patient is worsening. This is a Saturday. She's now on high flow. On Sunday, hospital day 14, she ends up in the PICU on more high flow. And at that point, the team says, look, we think this is autoimmune. We need to start steroids because she's getting worse, and we need to get her better regardless of not having a diagnosis yet. By hospital day 15, which is the day she's supposed to finally get her biopsy, she's now on BiPAP, and thoracic surgery says, look, she's too sick for us to take her to the OR and get the biopsy today. By hospital day 16, she's improving. Thoracic surgery will tentatively plan a biopsy on hospital day 7, but they say, steroids will probably decrease the yield, the diagnostic yield of this biopsy, so I don't know. But we press on, and on hospital day 17, she gets a VATS lung biopsy. While they're in there, it takes 3 hours by bronch to try to clear out a bunch of mucus plugs. And after that fairly extensive procedure, she's unable to be extubated post-op. Fortunately, this is not an M&M. She did get extubated the next day. She did have some complications from the procedure, and I would argue the delay in getting testing done when she was more well, when it was first asked for. She had a hemothorax and pneumothorax. And so anyway, to kind of cut to the chase of this, the biopsy eventually did confirm our diagnosis, which is eosinophilic pneumonia. And it's not on purpose. I'm only talking about vaping here, but it was felt to be due to her vaping marijuana with a sort of allergic type of pneumonitis as a result. She was eventually discharged home on hospital day 28. So to summarize her course quickly, first recommendation for bronch was hospital day 2. It actually happened 6 days later on hospital day 8. The first recommendation for a lung biopsy was on hospital day 14. Didn't happen for 13 days until hospital day 17. It took her 22 days to make the diagnosis of eosinophilic pneumonia, and her overall length of stay was 28 days. So I have to ask, would this same sequence of events have unfolded if this patient was thinner, if she didn't have a BMI of 54? Or what if she was white? What if her BMI was still high, but she was white and not black? What if she'd been male? What if she had been a combination? What if she was a skinny white female? What if she was a skinny white male? I remember several times during this course and afterwards as we dissected this case saying, a skinny white girl would have had this biopsy done way before this patient did. And that's, in fact, we submitted this and this was accepted as a poster of diagnostic delay at the Diagnostic Errors in Medicine conference in 2019. So I want to transition with that as our backdrop to what kinds of patients are subject to implicit bias, and then we'll explore more specifically the obesity, her race, and her gender as to what is the evidence that perhaps implicit bias does in fact impair our ability to make the right diagnosis or timely diagnosis. So there's a lot of our patients who are subject to implicit bias. This all comes from the evidence, including a National Academy of Medicine or an IOM report from 2003, way back then, about those populations that are indeed subject to implicit bias. They include women, They include the BIPOC population, Black, Indigenous, and people of color, the LGBTQ population, patients with a variety of psychiatric disorders, patients with a variety of addictions, obese patients, patients with low socioeconomic status, low educational status, non-English speaking patients, and the elderly are all clearly subject to implicit bias in healthcare. So if I try to break this down feature by feature, and we focus on the obese aspect of this patient's presentation, let's look at the evidence for obesity or weight bias in health professionals. So this is a study that was conducted at a conference on obesity. So these are professionals whose careers emphasize research or the clinical management of obesity. And what did that show? It showed very strong weight bias, indicating pervasive and powerful stigma. So people who spend their lives researching and treating patients with obesity have a strong and implicit anti-obesity bias. That the associations are between obesity and terms like bad, lazy, stupid, and worthless. And interestingly, the younger respondents and women actually had the strongest anti-fat bias. And I used anti-fat in quotes because that's right out of the paper. That's the terminology that they use. So, all right, there's implicit bias against obesity, but is there evidence that that impacts diagnosis? And in fact, there is. So we know that obese patients are less likely to receive routine screening, including pelvic exams, pap smears, mammograms, and colonoscopies. We know that clinicians spend less time in a room with obese patients. I talk to people all the time. I give lots of talks about diagnostic reasoning, clinical reasoning, and universally, when it comes up, it always comes up. If I had more time with my patient, I would be better able to make the right diagnosis. But we are choosing, in the case of obese patients, it seems that we, the clinicians, are choosing to spend less time in the room with those patients. Patients who report experiencing weight bias in healthcare are more likely to avoid future care. And the multiple studies have shown that. And patients report that physicians do have a tendency to attribute all their symptoms to excess weight and not really investigate other causes. And I have to admit that I have been guilty of this in the past, particularly when I was still doing some outpatient medicine. And I certainly have seen that in my experience. I'm sure that many of you, all of you, have probably seen some evidence of attributing all of a patient's problems to their weight. So if we move on to race bias, the fact that this patient was Black, could this have led to the delay in her diagnosis? So there is a lot written about this, and this is just a smattering of things. There's tons of papers out there, but what there isn't a paper on is specific to diagnosis or diagnostic error. There is no does implicit race bias or frank racism or structural racism cause diagnostic error in patients? There's nothing that says that. So it talks about treatment for the most part and disparities in how patients are treated, how they're worked up. So I had to kind of dig through a lot of this data in order to really come up with how does this specifically impact on diagnosis and misdiagnosis. Also, I want to point this out, specifically with regards to dermatologic diagnosis. We know that there is disparities for sure in the educational resources that are available to providers to be able to make dermatologic diagnoses in patients with darker skin. So this perspective piece was written by LaShara Nolan, who was actually part of the anti-racism podcast that I listened to that I mentioned in the beginning. She is a medical student, by the way. So the future, I hope, is bright for all of us, and we're going to learn a lot from the upcoming generation of docs who are already more aware of this than I ever was. So here's erythema migrans in darker skin versus lighter skin. This, any time that you Google erythema migrans, you get this image. It's this specific one. The shirt is the same. It is the paradigm of what erythema migrans looks like in white skin. And Art Papier was one of the authors of an article from quite a while ago that talks about how there are disparities in dermatology education resources. Art Papier happens to be the chief medical officer of Visual DX, which we all have available to us. And I just want to put a plug in for the fact that they have they report that they have more pictures of rashes in darker skinned individuals than any other resource in the world. And you can even search by skin tone when you are looking to make a diagnosis of a dermatologic condition. So I would just encourage you to remember we have this resource and to continue to use it. So a lot of what I'm going to talk about coming up comes from this core reference. If there's nothing else that you get from this talk, I would suggest that if this interests you in any way, that you check this out. This is from General Internal Medicine from 2013, Physicians and Implicit Bias, How Doctors May Unwittingly Perpetuate Healthcare Disparities, as was pointed out to me by those medical students that I, in fact, was doing. And it's 8 years old. It has been cited many, many times. It is really a core reading for those who are interested. So the first question that's asked in this paper, and they look at the evidence over years, is do physicians have implicit bias? I think we all know the answer to this, but here's an example, a specific study that I want to point out by Sabin in 2009. So they found that significant pro-white bias was present regardless of race, although Black physicians had less pro-white bias than non-Black physicians, and female physicians had less than white male physicians. But the take home here for me is even Black physicians demonstrate some pro-white bias. This is pervasive. It is influencing how we see things, how our brains work. Clearly. So I want to, we need to be open to the fact that this is happening to all of us. And I won't get into the background of why that is, but it is a robust finding across, there's lots of evidence that tells us we all have implicit bias to some extent in some populations. So does this implicit bias, implicit race bias impact clinical decisions? Well, again, from this seminal paper, they found in one case that these folks had no explicit race bias. So they didn't say, yes, I'm biased, yes, I'm racist, but they had significant pro-white implicit bias. And then when they had them study these, make a diagnosis or treatment recommendation for a patient a vignette patient, a paper-based patient who was Black, those who did have pro-white implicit bias were less likely to refer them for what they needed, which was thrombolysis in this case. But there was a subset of participants who, for some reason, somehow became aware or were told what the intent of the study was. And that impact on their decision-making actually seemed to go away when they were aware of what the study was looking for. So the conclusion here is, yes, implicit bias impacts decisions, but awareness of bias seems to mitigate the impact of implicit bias on our decision making. Another study that showed, it's again fascinating, physicians who had low explicit but high implicit race bias were rated more poorly by Black patients and had lower rates of patient satisfaction than those with low explicit and implicit bias. So that's not surprising. But what is surprising to me is physicians who had high explicit, who knew they were biased, who knew they were racist and high implicit biases were not rated as poorly by these patients as the physicians who did not express explicit bias, but did indeed have high implicit biases. So is it possible that having implicit bias is worse than knowing that you're biased? So in other words, being biased without being really aware that you're biased, is that worse than actually knowing you're biased? And at least in this study with regards to patient satisfaction and communication, that appears to be the case. So when we look at which potential diagnoses or diagnostic areas are impacted by race bias, there's evidence here from, you see multiple references down at the bottom there. So this is a conglomerate from multiple papers. Here's what we find. In general medical and surgical care, Black patients get less routine diagnostic testing, including labs and radiology. For coronary syndromes, Black patients, and really I'm referring to BIPOC patients, get less diagnostic angiography performed. Cancer screening, they get less mammograms, less pap smears, less lung cancer screening CAT scans. For stroke, less cerebral angiography and less carotid imaging are done. For kidney disease, that is a full hour or more on talking about the whole race corrections and kidney disease. So I'm not going to get into that, but if you're not familiar with this literature, I'll give you one guess as to whether or not these race corrections advantage or disadvantage Black patients. And of course, disadvantages Black patients. But there is one area where it seems that BIPOC patients actually do get diagnosed more. That is in psychiatric disease. So BIPOC patients are more likely to be diagnosed as psychotic. All right, so we've covered obesity, we've covered race. Now we'll talk about sex and gender. So the fact that this patient was female, did this potentially contribute to her diagnostic delay? So this is fairly well recognized that we do have a sexism problem in medicine. And again, I'm speaking specifically to how it relates to clinical care and clinical diagnosis, but that is not the only area where sexism in medicine is an issue. And I just want to point out the author of this online opinion piece is Maya Dusenberry. Because in 2018, when I attended the Diagnostic Era in Medicine conference, she was one of the speakers that I remembered and had a significant impact in that she gave this talk on how gender bias contributes to diagnostic delay and error for women. And it was one of these situations where I was like, what? How did I not know that this stuff is going on? So some of the following slides I have I've used from her presentation. Others are my own, and I will indicate that at the bottom and with the references. So the way that she kind of frames the idea of gender bias is that there's two gaps in how we approach medicine in with regards to sex, and particularly female sex and gender. That there's a knowledge gap in that the vast majority of medical research has been performed on men. This kind of, and even when you get down to animal studies and cell lines, something like 80+% of animals in animal studies for medical research are male. And most of the cell lines that are used for medical research as well are male cells. In 1973, couldn't believe this, the first study of the effect of estrogen therapy on cardiovascular disease outcomes, which was published in JAMA, enrolled 8,431 men and 0 women. I don't even know what to say about that. So people realized as early as 1990 and before that there is a problem with how we conduct research, in that we're spending a lot more time studying men's bodies than women's. And so the NIH Office of Research in Women's Health was formed in 1990. And the goal, the reason for this was to respond to concerns that a lack of inclusion of women in NIH-supported research could result in clinical decisions being made about healthcare for women based solely on findings of studies from men, without knowing whether these findings are actually applicable to women. So that was 1990. 11 years later, an Institute of Medicine report came out called Exploring the Biological Contributions to Human Health, Does Sex Matter? And they're saying 11 years later, sex should be considered when designing and analyzing studies in all areas and at all levels of biomedical and health-related research. There's still a gap in 2001. So let's fast forward another 10 years, 2011. In Circulation, there was a study called the Review of Sex and Gender Differences in Cardiovascular Disease Prevention. And their findings were that parity and inclusion had not been achieved, and analysis of outcomes by sex remained minimal, with evidence of such analyses in about 1/3 of studies. So not as many women as men were being included in the studies. And in cases where there were enough women to do an analysis by gender, that analysis was only done in about 1/3 of cases. So if we kind of summarize this field from 1990 to 2014, well, here is a quote from the director of that Office of Women's Health Research at the NIH that was founded in 1990. That the director, 24 years later, was still saying we literally know less about every aspect of female biology compared to male biology. So what's happened since then? I just looked at from 2020 to today, and what things look like in this area. And I found certainly there are still disparities in care and outcomes for women from minority backgrounds. There is still under enrollment of females. And here's an example study, and I'm not trying to pick on cardiology, by the way. These just happen to be the studies that popped up on my search. Looking at pharmaceutical research, this was published in 2020 in BMJ. The legacy of male bias within pharmaceutical research regulation and commercialization needs to be rectified, argue the authors of this paper. So still an issue. And then if we look at a bit of a summation of what's happened more recently, this is a 10-year follow-up studies so in 2016, there were still issues that people knew about the overrepresentation of male subjects in research. So the NIH implemented a policy that required investigators to consider sex as a biological variable. So then they went and they looked and said, how have we done since 2016? And they looked in 2019, and essentially they said, all right, we're doing better with regards to getting more women involved in studies, yet we are still not reporting data, so breaking out the outcomes and the findings by sex or gender. So one of the questions is, in many cases, including particularly in chest pain and MI, there's this impression that women present with atypical chest pain. Or the question is it not atypical for women? It's just atypical compared to the men who the majority of the studies that figured out what typical and atypical chest pain is were conducted on. So this is a fascinating study that was just recently published by John Brush. And he looked at, it's a complicated study. I'm just going to give you a quick overview. So he looked at all of these patients retrospectively who had come in and were found to have acute MIs. And he then went back, they did interviews with these patients, And they also they extracted from the chart just based on the historical findings of what was their pain like, what were the associated symptoms, and tried to really identify what are some and combined features. So if someone said, yes, I had substernal chest pain and diaphoresis and dizziness, they would say, okay, so there's a phenotype for a presentation with an MI. And if someone else said, I had back pain and nausea, all right, there's a phenotype. And so they took all of these clinical features based on the history and developed a bunch of phenotypes for what acute MI can look like. And if you see here that the phenotypes really were split, right? Like men present with a different constellation of clinical symptoms or phenotypes than women do, and there's not a heck of a lot of overlap. And so one way to look at that is to say, oh, look, women present atypically as we thought. Another way to look at that is to say, wait, women present differently than men. We need to do more research on women to understand those differences so we can get better at diagnosing MI in these patients. And then there is, I mentioned there's two gaps in gender-based and gender bias. The other is the trust gap. And this is not so much that women don't trust medicine, although they have good reason not to, but that providers tend not to trust women's reporting of symptoms. And this goes way back. So the term hysteria, it comes from the Greek word for uterus, way back in the day. And then Freud, as he seems to have done with lots of stuff, kind of really upped the ante on that and and basically said women are hysterical in that this is all in their heads. So Maya Dusenberry points out, here are some diagnoses that were formerly known as hysteria, things that we now know for most of these what the pathophysiologic explanation is, like fibromyalgia, chronic fatigue syndrome, interstitial cystitis, multiple chemical sensitivity. I have to admit, I never heard of this before this talk. Endometriosis, certainly, postural orthostatic tachycardia syndrome. These are all formerly referred to as hysteria. And in case you haven't heard of multiple chemical sensitivity, I had to look this up. It's a thing. It has its own up-to-date article. It's now called idiopathic environmental intolerance. It's poorly understood. It is much more common in women than in men. And I'll let you draw your own conclusions around whether that might be a reason that this is poorly understood. So if we kind of put this together, right, we have a knowledge gap. We have a trust gap in women's reporting of symptoms. Perhaps we can see, as Maya Dusenberry says, women's symptoms are not taken seriously because medicine doesn't know as much about their bodies and health problems. And medicine doesn't know as much about their bodies and health problems because it doesn't take their symptoms seriously. So does gender bias impact diagnosis? There's plenty of evidence for that. So women less than 55 are 7 times more likely to be sent home from the emergency department while they're having an MI because it's missed. 33% more likely to have a missed stroke. There are documented significant delays in brain tumors, bladder cancer, rheumatoid arthritis, and Crohn's disease. I highlight rheumatoid arthritis just to say rheumatoid arthritis is more common in women, yet men get diagnosed more quickly with rheumatoid arthritis. It's hard to understand. But at least in the face of Ehlers-Danlos, you know, men are a little bit disadvantaged too. It could take 4 years is the average time to diagnosis for a man with Ehlers-Danlos. Compare that to 16 years average time to diagnosis for a woman with Ehlers-Danlos. And I can't give a talk without talking a little bit about these classic cognitive biases that we have indeed talked about in the past. So just going to get into a few that are really relevant with regards to implicit bias. One is called fundamental attribution error, which is the tendency to blame people for their illnesses and not look for alternative explanations. So we kind of talked about this phenomenon with obesity, certainly in patients with psychiatric disease, patients who abuse drugs, abuse alcohol. We certainly have a tendency towards fundamental attribution error. Anchoring bias. So if we are influenced by implicit bias in some way early on in the course of our workup, we can become anchored to that. And anchoring is a tendency to fixate on specific features of a presentation too early in the process. And if those features happen to be obese Black female, that could really set us off in the wrong direction due to implicit bias. And confirmation bias, which really compounds any other type of bias, in that we have a tendency to look for evidence that confirms our initial hypotheses. So if we have an initial hypothesis that this is related to their obesity, and then we start looking for that, and in fact, this patient, it was postulated by some folks that the majority of her issues might be related to sleep apnea and obesity hypoventilation syndrome. So if we sort of put these two together, this can be very self-reinforcing. So I'm going to go see a patient, and I have this implicit association with women and anxiety. And so I ask a question, have you been under stress lately? Which I may not have asked a man. And, lately I get something like, yeah, duh, you ever heard of the pandemic? Like, who's not under stress? And so, my suspicion that this person's symptoms could be related to anxiety and stress has been confirmed. So there's confirmation bias. And we're done with our workup. Case closed, which is premature closure. And then I leave that encounter shaking my head and saying, women are so anxious. So that the next woman, I come into it with that reinforced implicit bias, and the cycle repeats itself. So what is a white guy? What are we to do about it? There's kind of three things that seminal article, the Chapman article I mentioned, really talks about. One is just increased awareness. And so I sort of pointed this out earlier, right? We have seen evidence where implicit bias does impact decisions, but if people knew that we were looking at the impact of implicit bias on decisions, it mitigated that impact. So just being aware that these things happen and are happening in our practice can be an important first step. And again, people who are aware that they are biased were able to make behavioral changes as a result of that awareness. So bringing the implicit and understanding that we do indeed carry implicit biases can be important. And to that end, anyone who hasn't read this book, I would recommend Blind Spot, which really gets into implicit bias and gives the opportunity to take the implicit association test if you haven't already. And even if you have, it's always a good reminder to do it again. And awareness is important enough that our chair of pediatrics had our entire department read this book a few years ago, and then we had some discussions based on it. Now, did that fix the problem in our department? Of course not. That's kind of a first step. We have to be aware of these issues. And then we get to the idea of individuating, which is defined as a conscious effort to focus on specific information about an individual. And that having specific information prevents us from filling in gaps with stereotype-based assumptions about those patients. And there was a fascinating study that shows we can literally learn to see the differences in individuals. So what this study looked at, training people who had difficulty in differentiating between different Black faces to learn to do that. So they had them take an implicit bias test ahead of time. Then they had them look at Black faces, and then they asked them later on and the next day, is this a Black face that you have seen before in this study or not? And they found that people really were not good at recalling which faces they'd seen and which they didn't. Then they did training where they just studied and kind of focused on differentiating between different Black faces. And in the control group, they did not do that training. And then they tested people again for their implicit bias. And in fact, implicit bias decreased for those who had been literally trained to see people as individuals. And then with regards to individuating real quickly, specific clinical information can also help. So there was a study where physicians were more likely to diagnose males with COPD, even though they would be presented with a female patient with the exact same history and exam and smoking history. But once providers were given PFTs that were consistent with COPD, that implicit association went away and got better. So seeking additional objective information is important. And then finally, perspective taking, and then I'll try to get to some of the questions, and I see quite a few questions in the chat. So this is a study of nurses where they showed them the faces of Black patients and white patients who are expressing pain on their face. And they asked the nurses, how much pain medication would you give this patient? How much morphine? And consistently, the nurses would give more pain medication to the white person than the Black person. But then they had a different arm where they said, look at this person. Think about what they must be going through, what they are experiencing right now. Try to understand how much pain they're in, what their symptoms are. And then they asked them, how much pain medicines would you give this person? And that mitigated the difference. So taking the perspective of the other resulted in the nurses deciding they would give equal doses of pain meds to a white or a Black patient. And then finally, and I won't get into this too much for time and because it's a big issue, the last recommendation for decreasing our implicit biases is to increase the number of underrepresented medicine minority folks who are in medicine. And I think the issue is here, as this National Academy of Medicine perspective points out, is that it's not enough just to have more folks, but we need to really change the system in which we work, the culture, the structural biases that we have in order to, A, get more folks interested in medicine and comfortable, and to then, put folks in leadership positions and everything else. So I will stop there. I hope I've made you a bit uncomfortable. Or if you weren't uncomfortable, maybe it's because you've already dealt with this and you've been through this. And I see a lot of comments. So I don't know if Dr. Skeist, if you want to, if there are specific questions you want to try to get to.
No, first of all, that was great, and it was very provocative, and made me think and for others about biases we hadn't even considered before. And so obviously you made some excellent points. So thanks again, Harry. If you could see the, can you see the chat, or do you want me to?
I can. So I'm seeing from the beginning, from early on, do studies correct for access issues that may be cause for less diagnostic testing or screening versus implicit or explicit clinician bias causing less testing? So yeah, so in many of the studies where I was just sort of saying, here's the evidence that there is in fact less good diagnosis happening in an underrepresented population, that included all of the above. So it likely included access issues. There has been no study that's really just looked at what is the impact of implicit bias in this outcome, except for paper-based vignette studies, which are somewhat hard to extrapolate to the real-world decision-making clinical setting. Does identifying patients at high risk for implicit bias immediately after admission have any effect on that bias? That I don't know. Certainly there's no evidence base to address that particular question. I think it's a bit of a double-edged sword. And yeah, I don't know. I think that probably if we have a team that is diverse in its thought, diverse in its appearance and background, and we work together as a team, I think that will certainly help to mitigate the effect of implicit bias, especially if we teach that team how to communicate really well with each other in a non-hierarchical way. Can we get rid of race-based GFR and CIS? I'm sure this is an ongoing discussion, and I don't know the details of that. I think that we should. All right, I know we're over we're at our time. How do we start calling people when we are aware of our biases or see colleagues engage in behaviors that are perpetuating bias? Yeah, so from Sharon Retzel, I think that's a question about how do we call out either ourselves or others when we're seeing them acting in a biased way. And I think, again, that gets back to the idea of if we can work in teams that are diverse, and we have a culture where it would be okay for someone to say, I noticed that you were acting in this way. You were saying these things to this particular patient. I wonder if that's related to some bias you have. I think we've tried to do that in pediatrics. If everyone reads Blind Spot and everyone takes the implicit association test and understands we all have some biases, then maybe that opens up that conversation to say, hey, because we do know for sure, this from clinical reasoning as well as other cognitive psychology, that we are much more able to see bias manifesting in someone else than we are to see it in ourselves. So if we could give people feedback, that would be fantastic. And I apologize, I think there are other important comments here, but for time, as we are over our time, I think we'll stop there. I'm happy to be in communication with folks by email, or to come back at some time to talk more. So thank you very much for getting uncomfortable with me and for inviting me for this talk, and have a good day.
Thank you very much.